Hi, it's Dr. Osgood, and I'm going to be talking about how do we evaluate someone with a coma. I think it's really important to start with what is consciousness and unconsciousness, and what is coma, and how do we determine whether someone is conscious or not. Then, how do we actually evaluate coma? What kind of exam do we do? How do we recognize the diagnostic signs that help us to tell where the coma is coming from? I also think it's really important to include a little bit of information on what things can look like coma but are not coma. Let's start with what's consciousness. I think it sounds really easy and straightforward. What is consciousness? But it's actually very, very difficult. For someone to be conscious, they have to be aware of themselves and their environment. Those are the two things that they need. They need to wake up and be aware. But consciousness occurs over a spectrum, and it's very important to be able to describe what you're seeing. And we're going to talk a lot more about that. But really, one of the most important things to describe what you're seeing is to know, how do you assess consciousness? Consciousness requires arousal and response. By arousal, it means the person needs to be able to wake up. If they can't wake up, they can't interact with their environment in any way, and they're not aware of themselves. And so in order to determine whether someone is able to wake up, the things we do is look for whether or not they can open their eyes. Do they look physically awake to you? Do they wake spontaneously, or did you need to give them a stimulus? For example, someone's eyes are closed. Do I need to give them just a loud voice, or do I need to give them pain for them to open their eyes? You also need to describe if they're alert. Do they wake up once you wake them up and maintain wakefulness, or do they fall back asleep readily? You want to describe what you see. As far as response, what we're really talking about is, how do they respond to voice and pain? Are they able to look at you? Do they track you? Are they able to follow commands you're giving them? Are they able to localize or withdraw? And how do they interact with their environment and others around? So to have full consciousness, you need to have both some ability for arousal and some ability for response. As I mentioned, there are various levels of consciousness. We can be awake and alert on one side of the spectrum, and we can be comatose on the other side of the spectrum. And while today I'm going to focus on coma, I think it's important to note that you may see all these various terms used to describe someone's consciousness. And what's really important is that you describe what you see. Are they awake and alert and respond briskly? Are they attentive, inattentive, and confused? What type of stimulus does it require for them to wake up? These things vary, and it's better to describe what you're seeing than to use a word that you're not sure the meaning of. If I say someone's stuporous, someone may not know what that means, and they may not know the difference between stupor and obtundation. And so instead of using these words, let's just describe exactly what we see. Do they wake up? How much stimulus does it take to wake them up, and how are they interacting with their environment? That way, everyone can tell if the person is worsening, if they're getting better, or if they're staying stable. We're going to focus on coma today as part of this lecture. Okay? And a coma is very, very specifically the inability to wake up and to respond to your environment. So the patient cannot wake in any way, and they cannot respond. And that's essential in determining whether they are comatose or not. When we have someone that's comatose, it's important to understand what parts of the brain are affected. The reticular activating system is a set of nuclei that are located in the brainstem, thalamus, and hypothalamus, and those control the ability of the person to wake up. Those nuclei project to the cortex, and those determine the ability for the patient to respond to their environment. And so when someone is in a coma, they have to have some impairment of their reticular activating system and some impairment of the connections going to the cortex. Here you have a sagittal slice and a coronal slice that are just showing you how wide those projections are. Generally speaking, I like to break coma into two separate etiologies. One that's structural, meaning it's a lesion in the brain or brainstem that's affecting the reticular activating system. Structural things come from things like vascular causes, stroke, neoplasm, which is cancer, infectious, like an abscess, or traumatic, like a traumatic brain injury, diffuse axonal injury, or brain contusions, or bleeding in the brain. Okay? So structural things are things that are within the brain itself that are impacting the reticular activating system, meaning they're impacting the brain stem. There are also diffuse things that lead to coma. Diffuse things are things that involve the entire cortex of the brain. Those are things like metabolic or toxic things, drugs, overdose, anoxic brain injury, meningitis, or a systemic sepsis where your whole brain is not functioning appropriately. Trauma can also be more diffuse in some ways, and then sometimes seizure. That's also a more diffuse etiology. It's important to recognize that there are some conditions that mimic coma but are not coma. These are the most common things that we would see. I think for us in neurocritical care, locked-in syndrome is one of the things that you may see. The person cannot open their eyes because that mechanism is weak, but they're not in a coma. So you may think that they can't wake up, but they actually can wake up. Akinetic mutism is when someone can't physically move and they can't speak, but they're actually awake. Catatonia is similar to that. They may look like they're unresponsive, but they actually can respond. So it's important to consider these things when you're evaluating someone with coma and trying hard to evaluate them in a way that may show that some of these things are possibilities. I want to go next into the neurologic exam because this is really the meat of the discussion, right? When we do a neurologic exam, we're trying to determine, one, is someone in coma, and if they are in a coma, where is that coming from? Is it a structural lesion in the brainstem, or is it something more global? The first thing we're going to start with is level of consciousness. Okay? Describe what you see. I already mentioned that multiple times, but does the patient wake up? Do they respond to their environment? Do they have purposeful interactions? And can they follow commands? Those are things that can help you determine their level of consciousness, right? In a comatose patient, they're not going to wake up, they're not going to follow commands, and they're not going to do anything purposeful. Okay? When someone is doing something, determining whether it's purposeful or reflexive is really important, but use these things to determine their level of consciousness. Your motor exam is also very important. Is a patient spontaneously moving? Are they moving just to pain? Are they moving to voice? And when they do move, is that purposeful movement or a reflexive or posturing movement? That's really important. In coma, you can have a reflex or posturing, but you cannot do anything purposeful. If you're doing something purposeful, you're not in a coma. Purposeful things would be localization or withdrawal, or tracking somebody or looking at them when they're talking with them. You also can do tone and reflexes, and just remember, when you see asymmetry on your exam, that helps to determine whether something is focal or structural, or whether something is more diffuse. If it's asymmetric, it's structural. Okay, that means if one side's not moving, or they only respond to pain on one side of their body, then that could tell you that something focal is happening. Let's get into cranial nerves because that's where a lot of our exam is, okay? We're looking at the pupils, eye movements, corneals, and cough and gag, and we're going to go through those, okay? So our pupillary reflex uses light to test cranial nerves 2 and 3. 2 senses the light, 3 constricts the pupils. And there are a lot of pupillary abnormalities that we might see. So a normal response is in the dark, your pupils are big, in the light, your pupils are small. That's normal, right? In a situation where your pupils are small to begin with, but they react to be even smaller, that might be something toxic or metabolic, like an opiate. They start out small, but they're still reactive. Another situation that we see commonly in neurocritical care is one pupil is dilated and that pupil does not respond to light. So you have a fixed and dilated pupil. The other pupil responds appropriate to light, and that's a third nerve compression problem or brain herniation. Another situation that we also sometimes see in neurocritical care is when both pupils are fixed and dilated, or both pupils are midpoint, but also fixed. And that's related to compression on the midbrain itself. Another situation is when your pupils are very, very, very tiny, almost small, so small you can't see them. So pinpoint pupils that react, that could be from the pons. And so those are some of the signs and symptoms you want to look for to help you to localize the lesion. When we talk about extraocular movements in someone with coma, we have to talk about Dahl's eyes and caloric responses. So we're turning the head from side to side. We're activating cranial nerve 8 in order to have the eyes move through cranial nerves 6 and 3. And this is testing your pons and your brainstem. So we turn the head side to side, and we should see that the eyes move into the opposite corner. So if you turn your head to the right, your eyes are going to move sort of towards the corner on the left. And that would be a normal response in someone who is in a coma that had a normal brainstem. If you can't turn their head, they have a cervical collar on, they have a C-spine injury, you may want to do a caloric response where you put cold water into their ear. A normal response in coma would be that the eyes look towards the cold stimulus. You might see an asymmetric response where only one eye moves over, and that could tell you that there's a structural lesion. And in the other case, like brain death, when you put the cold water in, the eyes don't move at all. Corneal responses are checking cranial nerves 5 and 7. So we're touching the cornea, which the sensation is 5, and the response to blink is cranial nerve 7, and that's located in the pons. You want to make sure that you're cutting and touching the cornea and not just the sclera. Cough and gag are the other brainstem reflexes that we check. So we want to use inline suction to check a cough and a Yankauer to check a gag. And we're looking for cranial nerves 9 and 10, and those are located in the medulla, so the bottom part of the brainstem. So just in summary, as this was a lot of information in a short period of time, is that coma requires you to have impaired arousal and impaired response. Coma can be structural or it can be diffuse. Our examination of going through level of consciousness, motor, and cranial nerves help us to determine what the cause for coma is and also follow for changes over time. And be aware that certain things can mimic coma, and you want to rule those things out when you're seeing someone with a comatose exam. Thank you.